typically do the ortho examination is we'll do sort of a look at general range of motion, but it also is going to be driven off of what you see on the exam sheet. If someone has a history of shoulder dislocation, you're going to focus on the shoulder. Knee injury, you're going to really focus on that. But a lot of times I will just start just to look at full range of motion and just have the patient lift their arms up above and make sure the motion is symmetric. If one arm's down, that'll be something to worry about. Other thing is I sometimes will have them put their arms like this and turn back as far as they can, and then turn in as far as they can. And they should have, as you can see, the broad range of motion of Connor here. We should see that. If there's loss of motion, that's something to focus at. But that's the very quick exam there. I may have to give me a handshake on both sides, make sure both elbows straighten all the way and bend all the way. Not a problem there. And if there's any issues of hand or wrist injuries, we'll look at those as well. But usually these things are going to be totally normal. You can also look at pronation, supination of the forearm. In rare cases, you might have a stiffness problem there because of a previous injury. In terms of the hip and knees, I'll have them lie down, kind of go from the seated to lying position because it's fairly efficient. Once again, if someone has a history of an injury, I'm going to focus more on that. But just some very basic things. A lot of times I'll put my hand behind the leg there to encourage it to flex. We'll flex in and out, make sure this doesn't cause any pain or discomfort from the hips. Okay, same thing here. They should have good and symmetric inward and outward rotation of both hips. Okay, no pain or discomfort. The knee exam, once again, a motion exam. Usually it's going to be fine. Totally relaxed there. Kind of do the very quick Lockman test, which without a history of knee injury, probably not going to find anything. Posterior drawer and anterior drawer test. And then we can do a little varus and valgus stress test in about 34 degrees of flexion. The vast majority of these will be totally normal, but you'll do it on both sides. Same thing with the ankle. If they've got a history of foot and ankle injury, you're going to focus your attention a little more, a little more detail, especially with lateral ankle sprains, checking the lateral ligament complex about the ankle. And if a history of injury, you might even do some drawer or varus stress testing. But most of the time, the patients are going to be pretty normal, and I focus on symmetric range of motion of the ankles and the subtalar joints. So back and spine, go ahead and stand up there for a sec, Connor. And Connor, I'm going to have you, we'll have you face the wall here, so you can, I'll stand offset a little bit so you can see. Things we look for in the back and spine, if they're in tank tops or shorts, it's very easy to see things. First thing I like to look for is shoulder symmetry, scapular symmetry. Sometimes the first thing you'll pick up if someone's got a spine problem, scoliosis or kyphosis, is that they've got shoulder asymmetry. There's frequently the dominant arm may be a little bit more developed in the trapezius, or it might be a little bit higher in the thrower or dominant side, but for the most part, close to level. The other things was we'll look for the back, and you want to make sure there's a little bit of a lumbar thoracic curve here. But if you notice the kids are really hunched over, that's something you want to look at, and they could have a problem with Schurman's kyphosis, but it's pretty rare. So to check for the contour of the spine, one thing I like to do is have the patient slowly lean forward, have them keep their head straight ahead, and slowly lean forward, let your arms dangle down at the side, and you can go ahead and lift your head, go ahead and go forward. Now stop about halfway down, and you look for a hump. You look for asymmetry, because if someone's got a rib hump where one side's more than a few degrees higher than the other side, you might have some type of scoliosis or spinal deformity. Go ahead and bend over further. If you see a hump down here, it could be a lumbar curve as opposed to a thoracic curve, which once again, you would see an asymmetry, a rib hump or a flank hump. The flank hump could be scoliosis. Sometimes you can have a leg length discrepancy. So if someone has a 1 or 2 or 3 centimeter longer leg, thigh combination, it'll lift that side up. So it doesn't necessarily mean they've got scoliosis. It could be a leg length discrepancy. One final tip about the musculoskeletal exam, it's very helpful to watch kids walk as they come into the room. You can usually watch at least 10 or 15 steps as they're coming in the hallway into the room. If you notice a limp, a gait asymmetry, something to get your attention a little bit out of balance, that can be a tip to other problems. It can be a scoliosis, it can be a leg length discrepancy, there could be a hip problem. Sometimes a slip capital femoral epiphysis, the only indicator is someone's got a little bit of a limp or a history of a little bit of hip pain. So those are the things you really want to pick up on. The other thing we occasionally see is we'll see kids with knock knees or with bow legs. A big difference, you look at them and they look knock knee or bow leg, that's something that should be referred to an orthopedic surgeon, because sometimes that's something that should be addressed, and if it's identified early, the treatment options for it are very simple and very low risk as opposed to something that's identified late.